And as we're about to find out, the frontotemporal dementias is just that, dementias. Again, glad that you're here. I'm Holly, and I am the Director of Education and Family Support Services. And today we're going to talk about understanding frontotemporal disorders and degeneration. FTD, as it's often called, or the FTDs, because we're going to find that FTD itself is its own umbrella. There are different disorders, degeneration, diseases that fall under the FTD umbrella. Most of the time, FTD is just kind of grouped together, and today we're going to dissect it. And this is just going to be a high overview because we could probably spend about 4 hours really doing a deep dive into FTD, but we're going to do a high overview of the most common types of FTD. This is one of a very few of the dementias that can present with no memory loss. So people will often hear dementia, and of course, they immediately think memory loss. But FTDs, the frontotemporal dementias or disorders, and Lewy body dementia or dementia with Lewy bodies are two that can present with no memory loss. So we're going to dive into that a little bit further. Here's more information about us here at the West Center. If you'd like to know more, our admissions director is named Lindsay, and right there is our phone number. We are residential care, respite care, day program, and short-term rehab. And starting July 1, we will have in-home care as well. There's our objectives for those of you who are getting CEs today. And let's start with just some basic dementia general information. Again, high overview. So that word dementia. Dementia is just an umbrella term itself. It's used to describe a range of conditions which cause changes and damage to the brain. Under the dementia umbrella, there's over 130 different types of dementia. You can see under that umbrella there's all types of dementia. And there's, on this particular graphic, it says frontotemporal. FTD actually has its own umbrella because there's all these different types of frontotemporal dementias or disorders. Vascular dementia has its own umbrella because there's all types of vascular dementias. But today we're focusing on FTD. That word dementia, again, it's so much more than memory loss, as most of you already know. But let's look at the actual definition from the NIA, the National Institute on Aging. Dementia is the loss of cognitive functioning, thinking, remembering, reasoning, behavioral abilities to such an extent, here's the key, that it interferes with a person's daily life and activities. If it's not interfering with a person's daily life and activities, it's mild cognitive impairment. Mild cognitive impairment, MCI. But once a dementia crosses over to the point that it's interfering with daily life, now we've got a dementia diagnosis, and then we can find out what type, kind, or form of dementia. There's been a lot of information about FTD lately because of a very famous actor and his family. Bruce Willis's family has been remarkable about being upfront and honest about his diagnosis. This is a statement that was made from Bruce Willis's wife and his family in February of 2023. Now, this is Alzheimer's and Brain Awareness Month, and I saw something this week that his wife has just recently written and released a book about everything she wished that somebody would have told her when they got his diagnosis. Because she said they were given the diagnosis, they didn't get a pamphlet, they didn't get a brochure, they did not get hey, you might check out the AFTD, nothing. Here's some medication, try this, we'll see you back in 6 months. And they've got all the resources in the world. And I know it happened to you because it happens to everybody. We hear it over and over again. So I want to take a minute. I'm not going to read this whole thing to you, but I want you to see, and Jamie's putting the slides in the chat, and you're going to get a copy of these. So you can always make copies of these. So He was diagnosed with aphasia in the spring of 2022. We're going to talk about that. And she says Bruce's condition has progressed, and we now have a more specific diagnosis, frontotemporal dementia, known as FTD. His started, though, as aphasia, which I'm guessing that many of your loved ones probably started as aphasia as well. Primary progressive aphasia. Again, we're going to talk more about that. And look what they say in, okay, this FTD is a cruel disease that many of us have never heard of and can strike anyone. For people under 60, FTD is the most common form of dementia. And because getting the diagnosis can take years, FTD is likely much more prevalent than we know. Today, there are no treatments for the disease, a reality that we hope can change in the years ahead. As Bruce's condition advances, we hope that any media attention can be focused on shining a light on this disease that needs far more awareness and research. And I applaud that family. They're not trying to hide it. They're not being ashamed of it. They're making it, and they're putting it out there so everybody can know about it. Now, she also puts information about the AFTD in the second to last paragraph there. And then we'll talk more about it as well. It's a great organization. I encourage you, if you're not familiar with AFTD, Google it, go to AFTD. They have support groups specific to FTD. They also have resources and some funding that's available for some respite for people who have FTD. Go to AFTD. Okay, so again, introduction. What's going on in a person who has a frontotemporal disorder? It's progressive nerve cell loss in the brain's frontal lobes, the area behind the forehead, and the temporal lobes, the area behind the ears. So we're talking about this part of the brain. As the neurons die, the lobes of the brain atrophy or shrink. With other dementias, we tend to see the atrophy or the shrinkage at about the same rate. The brain's beginning to atrophy. What's very different about FTD, and we're going to look at some scans in just a minute, is where we're going to see the shrinkage or the atrophy is right here first. With that being said, then, why do they not have memory loss first? Because that's not where memory's held. But what's held right here, executive functioning, personality, behaviors, language, emotions, planning and sequencing, reasonable and rational decisions and behaviors, judgment, prioritizing, sequencing, the ability to multitask, movement. Nowhere in there did we mention memory loss. Think of all the things that these folks get misdiagnosed with first. And you heard from that letter from the Willis family. It's the most common type of dementia now in people under the age of 65. She said 60. It's 65. So we've got somebody who might be in their 40s or 50s, and they're having changes to their personality and behavior. What do you think they're going to get diagnosed with? They show up to the primary care physician first, and 9 times out of 10, they're going to start thinking it's a psych issue, that they're having some mental health issues. Why would dementia cross anyone's mind if they're 48, 50, 53, 60? And it's the most common type of dementia for people under the age of 65. So it's also called FTD, frontotemporal lobar degeneration, and you may have heard the term Pick's disease. And again, we're going to break these down. But first, let's look at some pictures. This is some neuroimaging of cognitive impairment. And the one that's on the far left there, that is normal imaging. There's an MRI and a PET scan here. So you can see normal. And in the middle, we have Alzheimer's. And on the right, we have FTD. Now, what I want you to look at in that FTD is look right up here at the front. Look right up here where those arrows are pointing where it says FTD. That's the frontal lobes. On Alzheimer's, the atrophy is close to the same, and then there's the normal 3-pound brain. But in FTD, we don't have hardly any atrophy at the back, but we've got all kinds of atrophy up here at the front. So let's compare it side by side with Alzheimer's disease, because Alzheimer's disease is the most common cause of dementia in people over 65. So when we put them side by side, and you are getting these slides, Jamie's put them in the chat and then she'll email them to you. Alzheimer's disease, our chances actually, age is the one thing we have going against us with Alzheimer's. Now, that doesn't mean everybody's going to get it because it's not a normal part of aging, but it increases with age. FTD, it's almost always people under 75. In fact, it's usually before the age of 65. Early behavioral problems, common in FTD, unusual in Alzheimer's. Socially inappropriate behaviors, very common in FTD. In Alzheimer's disease, it can happen, but it's usually just in really rare or severe cases. And by socially inappropriate, I mean saying things, doing things, the filter's gone. Don't say that, don't do that, don't, yes, say that, yes, do that. But they are still driving, they are still working. I had a gentleman whose very first sign was he started yelling very obscene things at cheerleaders at his son's football game, sexual things. Out of the blue, this started. That's how he started. He started taking things from the church during Sunday mornings. He would go through the rooms and just take random items and go put them in the car. He was running a major company. He wasn't having any memory issues. It was coming up as socially inappropriate behaviors. Look at the language problems. In Alzheimer's disease, the language problems associated with memory impairment, but in FTD, isolated language problems without memory impairment. Now, the memory impairement's going to come. The visual spatial defect. It's very common in Alzheimer's. We don't see it as much in FTD. It will come. It's going to come later. The motor signs, the mood, marked irritability, being withdrawn, difficulty in understanding their own emotions, which can lead to anger and anger outburst. Because when someone is frustrated or they're scared, a lot of times it will come out as anger. Anger is the easiest emotion for most people to have or to feel. Psychotic features, appetite and dietary changes. Now, that doesn't mean every person's going to do all of those things, but those things are common. So let's look at another slide here. And I mentioned Pick's disease earlier. This is a picture of Pick bodies, and we'll see where that comes from. But let's talk about a few terms. First, we're going to talk about the most common. It's called BVFTD, Behavioral Variant Frontotemporal Dementia. It's the most common. It's responsible for about 50% of all cases. And sometimes when people say FTD, this is the one they're talking about because we see it so often. Behavioral Variant FTD. Then you may have heard the term Pick's disease. They don't use this term very often. It's the original name of FTD because of Dr. Arnold Pick, who in 1892 described patients with distinct symptoms that were very different from those that there was also a Dr. Alzheimer and a Dr. Lewy. Those may sound familiar when you know a lot about all the other different dementias. This term is now used to describe abnormal collections on the brain called Pick bodies. Some people with BVFTD have them, some don't. Then there's also FTLD, frontotemporal lobar degeneration. Sometimes people just use the term frontotemporal disorders, frontotemporal degenerations, or frontal lobe disorders, where they're talking about changes in behavior and thinking due to damage in the frontotemporal part of the brain. It is not a single brain disease. This is a family of related neurodegenerative diseases. So, FTDs, the FTDs are a form of dementia. Again, the most common type of dementia in people younger than 65. 60% of people with FTD are 45 to 64 years old. Life expectancy, on average, is 7 to 13 years. Now, you've got to keep in mind that's on average. That means that there's some people that are going to live 20, and there's some people that are going to live 2. You've got to take comorbidities into play, and you've got to take a person's age when they're diagnosed into play. It is progressive. It is terminal. If they do not die from something else, this is a terminal disease. And in those early stages, they could just have one symptom. That's another reason it goes misdiagnosed for so long. But as it progresses, those other symptoms start to show up because the rest of the brain is being affected. There's no cure. There's no treatments. We don't know how to stop this yet. There's not as much funding pushed toward the FTDs as there is pushed toward Alzheimer's because it's the most common. We've got a lot of money being pushed toward Parkinson's right now because of Michael J. Fox coming out and being open with his Parkinson's for now over 30 years. And that's what the Willis family is trying to do, is to get some attention on FTD. And let's get some funding pushed toward FTD. And some of this repeats just a little bit, so I want to point out just a few things. Strong family history. About 50% of the time, there's a family history, and it's 4 times more common in men. And I've mentioned it's often misdiagnosed as a mental illness because the person can even be in their 30s. Sometimes they will get a diagnosis of schizophrenia, bipolar, major depressive disorder, and meanwhile, it's FTD that is progressive and continuing on. We are going to watch a short video about FTD before we continue on. There it goes.
Let's talk about frontotemporal dementia. It's a long term and a scary one, but it's important to understand what it really means. Let's break it down. Fronto and temporal refer to the parts of the brain affected by the disease, the frontal and temporal lobes. The frontal lobes are in charge of executive functions like planning, prioritizing, and multitasking. They also help you decide what's important in different social situations. For instance, it's your frontal lobes that enable you to follow directions in a recipe and to talk quietly in a library. The temporal lobes play a major role in language and emotions. They help you understand words and communicate. They also help you recognize objects and people and control your emotions and figure out what may be triggering them. Someone with damage to their temporal lobes may not understand that a hot stove is dangerous or why you're worried and upset when they try to touch it. The temporal lobes also manage memory storage. However, for most people living with frontotemporal dementia, or FTD for short, memory changes are not a major symptom. That's one of the many ways FTD is different from other common types of dementia like Alzheimer's disease. Here's how else they compare. FTD usually affects younger adults. It is the most common form of dementia in people under the age of 60. Symptoms of FTD usually start in people aged 45 to 64, but may also occur later in life. Also, FTD is less common than Alzheimer's, and much less is known about it. It is frequently misdiagnosed as Alzheimer's, depression, or a psychiatric illness. On average, it takes 3.6 years to get an accurate diagnosis. Unfortunately, there is no cure for Alzheimer's or FTD. but some treatments are beginning to emerge. That's why it's so important to take part in clinical research if you can. When it comes to FTD, like everything, knowledge is power. It is critical to get the right diagnosis. This will help avoid potentially dangerous medications you don't need and empower you and your care partners to prepare for the future. Learn more about dementia and get the support you need by calling 858 49.
I am guessing that some of you, while that video was going,
92.
heard your own story being told there. Wasn't it interesting? And this is something that we see a lot. We can see it with all of the dementias, but especially in FTD. You saw the little graphic about they're standing there and there's a pot on fire on the stove and the person's just looking around. It's not that they don't see it. It's not that they don't smell it. They don't make the connection that this is danger or what to do about it. That's hard to understand. That's hard for us to wrap our mind around, especially when that's our loved one that we know they know better until they don't. And they don't. The connection is what is missing. The connection is missing. Where they may smell something that if we smelled smoke, we'd immediately go look to see danger. If we heard a siren going off or the smoke alarm going off, we would get up to go check it out. And it just might be an annoying noise to them. So let's look at some symptoms. Right up here at the top. Inappropriate social behaviors, shouting in public, laughing at a funeral, difficulty in reading social signs or reading the rooms, that kind of thing. That video mentioned that difficulty in making decisions. They can get very hung up on these little small details and ignore great big aspects. They don't see the big picture. A lot of trouble managing finances. It's really common. In fact, a lot of times families will say that's the first place it showed up. They stopped paying bills or they were paying the same bill multiple times. Engaging in purposeless activities. This is really early in the disease, where they may do something over, like a repetitive type motion over and over, which is really normal in the dementias later in the disease. But they could still be working, driving, going to church, having a life, talking, doing everything, but they get obsessed with some small activity. Sorting is one of those. I've had people say they get almost obsessed about sorting. I've even had people describe it as it's like they develop OCD, obsessive compulsive disorder, where everything has to be just so. Now, again, this isn't everybody. Maybe having some trouble forming sentences. The words are there, but they can't get it just right in the sentence. The motor difficulties, because we talked about motor being from arms, legs, mouth, stiffness, balance, that neuromuscular weakness. And then not only struggling with words, but I want you to consider this also. Sometimes we think, well, they just can't speak, but they can understand. But sometimes they can't understand. It's not just that they're losing the ability to say the words, they're losing the ability to understand the words. Now, there's a type where they can still understand, but they can't speak. We're going to talk about that one. This is interesting. With writing, this is one of the tests they'll give sometimes, is they will ask them to write or spell words. And this is a common one, is to ask someone to write the word all, A-L-L, and they can't write it, but they'll ask them to write alligator, and they can write the word alligator. It's an interesting disease to study. And then again, trouble finding words. I've got another really good example of this from a family member. They were starting to downsize this man's shop. Had this huge shop filled with tools, extra wood, all kinds of things, an entire garage. And he got obsessed on the nuts and bolts and screws and nails. And he wanted little baby food jars, and he was sorting nuts, bolts, screws, and nails. Meanwhile, the entire room needed to be cleaned out. And she could not get him off of sorting the nuts, the bolts, the screws, and the nails. So I told her, let him sort them. Let him sort them. That's what he needs to do. He's contributing. He's got a purpose. He's got a reason. Everybody else work on everything else. That's an example. Some more symptoms of FTD. Again, that stealing could be on there, sexual aggressiveness, vulgar language, loss of inhibition. We've talked about shouting in public or laughing in inappropriate places. Apathy also is pretty common, where it just seems like they don't care. They may even say, I don't care. That gentleman I talked to you earlier about, who was taking things out of the church, whenever his wife asked him about it, he said, I wanted it. I wanted them. That's why I took them. Okay, well, that tells you right there his filter isn't working. We don't just take things that we want. It's also common pretty early in the disease for them to develop a flat affect, a flat facial expression. They may also develop a fear of having a serious illness. That's something you might see. And memory loss will come. It will come eventually. It's later on in the disease. And the ability to take care of themselves will also be lost later in the disease as the dementia progresses. We've mentioned executive functioning, planning, and sequencing. Well, what else has a lot of sequencing? Activities of daily living has a lot of sequencing. The ability to take care of yourself. How many steps are there in taking a shower and brushing our teeth and shaving and doing our hair, putting on makeup, getting dressed? Thinking through the steps becomes an issue. Not being able to multitask. And then that ability to self-monitor. Sometimes they're not even aware of their space. That makes sense. Repetition, we can see that. Compulsive eating, gorging, especially on starchy foods, is pretty common. Taking other people's foods, pretty common, just reaching over and taking other people's food. That's part of the impulse control. Having a hard time resisting impulses, touching things, reaching out and touching people, wanting to hug, kiss, lick on other people. Had people tell me that before about licking. Lack of interest, drive, or initiative. That's also some of the apathy. And there can be a lot of anger associated with the FTDs. Part of that anger can come from the frustration or the fear. Part of it comes from, especially early on when we don't have a diagnosis or we don't have the right diagnosis, they still are reading and picking up on us. So we're getting upset, so they're getting upset because they're reading our emotions. They're reading our frustration, and they don't know what's happening. They've got problems recognizing their own emotions, so they won't always respond appropriately. They don't tend to recognize danger. So on that video, it showed the pot on the stove, boiling water, reaching down for a snake, picking up a knife by the blade, not using the gun appropriately. Gait disorders we've talked about. They may even have a tremor. So they could, especially if they're having those gait issues. What's that sound like? They're having some gait issues. They've got a tremor, the age, and they show up at the doctor and they automatically think Parkinson's. And it isn't Parkinson's. So let's look at some causes. About 40% of the time with FTD, it's genetic. It's a gene mutation. And I put on this slide the specific genes. If that is something that you're interested in, you can do some more homework on that. And I've put a really good website on here. It's part of aftd.org. And then you put in FTD/genetics. And again, you're getting these. You're getting a copy of these. They're in the chat, and Jamie will send them to you with the follow-up video. So those are the mutations that we tend to see whenever it is genetic. This is another graphic that I just wanted to show you. Each of these are umbrellas. So semantic dementia, we're going to break these down. Semantic dementia is characterized by the inability to match certain words with their images or meaning. This is part of semantic memory. So they may, in testing, give them pictures and then the written word, and you have to match them up. So there's a picture of a hippopotamus and a rhinoceros and a giraffe and an elephant, and then all the words are on cards and you have to match them. Excuse me. So a semantic FTD, they would have a very hard time doing that. In this particular type of dementia, patients with this disorder retain the ability to speak quite fluently, as well as the ability to remember day-to-day events, because that is episodic memory. Episodic memory is our day-to-day events. Semantic dementia is a subtype of primary progressive aphasia. So we're going to break this down even further. So primary progressive aphasia can even break down into semantic dementia. Excuse me, I'm so sorry, I got a tickle. It can also be called Broca's or non-fluent aphasia. People with this pattern of aphasia may understand what other people say better than they can speak. People with this pattern of aphasia struggle to get the words out, and they often speak in very short sentences and will omit words. Another good graphic is this one. So there's that frontotemporal umbrella, and there's the behavioral variant frontotemporal dementia, BVFTD, the changes in social conduct and behavior, the loss of empathy, apathy, disinhibition, no insight. Look at that brain. Look what's going on in that brain. That's an MRI. Can really see the changes there, this frontal part. Now, here's that semantic dementia, the one we were just talking about. That loss of semantic knowledge, the being able to put the word with the picture, the impaired word comprehension and object naming, but they're speaking fluently. Look at what that brain looks like. There's a difference there. And then there's the progressive non-fluent aphasia. Apraxia and effortful speech, spared object knowledge, and word comprehension. And you can see how the brains differ with those scans. So here's those disorders. And again, as we continue to break them down, the progressive behavioral personality decline, we see more in the BVFTD. And then this is also some of the things that they're called. It may be called TVFTD, FVFTD. There's the progressive language decline that we see in primary progressive aphasia. That's what Bruce Willis has started at. It was the aphasia. Progressive non-fluid aphasia and the semantic dementia. And there's the progressive motor decline in people who have corticobasal syndrome, and we're going to break these down, progressive supranuclear palsy, FTD with Parkinson's, and FTD with ALS. So yes, a person can have two different types of dementias at the same time. It's called mixed dementia, but a person can also have two different diseases at the same time, just like a person can have two different cancers at the same time or four different cancers at the same time. A person can have multiple dementias going on. These are the ones that we see the most often. Again, it's going to break it down just like that graphic showed. The primary progressive aphasia, usually those folks are between 45 and 65. The corticobasal syndrome, the supranuclear palsy, those present with physical movement disorders. A progressive motor decline, that's how they present, where the primary progressive aphasia is going to present with the issues with language and communication first. The BVFTD is going to present with the changes in personality and behaviors first. So let's break them on down, and let's look first at the most common type, the BVFTD. This is the one we see the most often. It has been recorded as early as people in their 20s and as late as people in their 80s. So when we talk about that average, we're talking 40s, 50s, 60s. Personality and behavior and judgment changes first. This is why they get misdiagnosed as having some type of psychological issue. They many times are going to act very strangely in social situations or inappropriate and have impulsive behaviors. And here's a key: they don't recognize that their behavior is offensive. They don't recognize it. In fact, there's not anything wrong with them, there's something wrong with you. Not showing any consideration for other people's feelings or emotions, they can develop kind of a flat affect. The picture that you see there, don't care. Just kind of has that look of don't really care. They will eventually develop language and movement problems. Memory typically is intact. The next most common is the PPA, the primary progressive aphasia. This is the one that presents with trouble with communication. It can show up in reading, writing, speaking, and understanding. They will develop problems with their memory, reasoning, and judgment eventually, but it's usually not there at the beginning. They can develop the behavioral symptoms or those challenging expressions that we see in BVFTD. And then primary progressive aphasia breaks down into 3 other categories. Like I said, we can go way deep in the weeds with the FTDs. But the 3 that we tend to see, that semantic PPA that we talked about earlier, slowly loses the ability to understand words and sometimes the ability to recognize objects. Progressive non-fluent aphasia, more and more trouble producing speech and sounds, omits connecting words and sentences such as to, from, the, leaves those out, and can develop symptoms like the corticobasal syndrome. And the last one, trouble finding words but can understand words, has a hard time speaking but can comprehend. So let's look at this one a little closer. The progressive supranuclear palsy, PSP, and the corticobasal syndrome, CBS. The PSP, this one causes a lot of problems with balance and walking, lots of unexplained falls, that flat facial expression, body stiffness, trouble with eye movement, looking down a lot, and they can also develop those behavioral issues. CBS causes the progressive loss of the ability to control movement. This is usually around the age of 60 that this one gets diagnosed. And it usually starts in the hands and arms, where they're having a hard time with the use of their hands and arms. It typically appears on one side of the body first, but eventually both are affected. Arms and legs can become uncoordinated and stiff. They can develop speech problems, a hard time orienting objects in space, maybe overreaching for something, reaching over or missing a chair, developing movement symptoms, difficulty with fine motor skills, and swallowing. Other motor decline. We mentioned this one earlier, frontotemporal dementia with Parkinson's or Parkinsonian syndrome. It's a slow movement, very similar to Parkinson's, with stiffness, and then they also have changes in behaviors and language. And then the FTD with ALS. ALS is also known as Lou Gehrig's disease, and so a combination of both of those diseases leads to muscle weakness, jerks and wiggling in muscles, and changes in behavior and language. So how in the world do we get diagnosed? We always want to start with the primary care physician. We're going to start there. We're going to do complete blood work. They should be then sending on to a neurologist, a psychiatrist, a psychologist, somebody who can diagnose, because many times, as we've said, that video said 3+ years to get a proper diagnosis. Neurological exams and brain scans, because in an MRI, we've been looking at MRI on this program, And even when you're not in healthcare, when you kind of know what to look for, you can see that FTD. You can see the changes in the frontotemporal parts of the brain. They should get a complete record of that person's symptoms, personal and family medical history. This is where families are going to need to be talking about doing education, because we saw that 50% of the time this is in families. A physical exam, blood test to rule out other similar conditions, genetic testing if appropriate, and then those neuropsych evaluations. The neuropsych evaluation is where they're going to spend 4 to 6 hours in neuropsych, and they're going to go through a battery of tests to be able to come out and tell us about their cognitive functions. Let's take a look at this brain. And again, if you will look up here, now this is a severe, severe case of FTD. This would be very, very end stage, because look what's left of this brain over here. And look right here in the front and the temples. And then look back at the back. Treatment and management. What we've got to learn how to do is manage those symptoms. We treat the symptoms. We've got a support team of our doctors, our nurses, speech pathologists, occupational therapy, physical therapy, educating ourselves as the healthcare professional or as the family caregiver. We learn to manage behaviors by not arguing or trying to be reasonable with somebody with dementia. That's not going to work. Try to be as sensitive as you can. Go to their world. We can't bring them to our world. Those behaviors have a meaning. What are they frustrated about? What is a need that's not being met? What are they trying to get across to us that they're not being able to get across to us? Limit their choices, and keeping a routine is important. Medications. We don't have any medications that are specific to FTD. We have medications that are for symptoms. Right now, there's a couple of new infusions that are specific to Alzheimer's disease and MCI, mild cognitive impairment. They're still new. They're trying them, but we don't have anything yet for the FTDs. Now, we've got a picture on here of a card. It's the size of a business card, and it's for families to have with them, and it says, "Please pardon my language or my behavior. I have a brain disease called frontotemporal dementia. Thank you for your patience." It is something you can get through the AFTD. You can order them off of their website, which is there, the aftd.org. And it's something that you can carry with you. So if you are in a restaurant or you're in an office somewhere, wherever you are, and your loved one has some of these challenging expressions, you have these cards with you. A lot of people use these for all different types of dementias. You can even make your own. I had a family member make her own that said, "Please excuse my daddy. He has Alzheimer's disease. He may," and it was just on a little card. It even had his picture on it. Other treatment and management. Again, it's educating yourself. I hear it so often in families who get into support groups and get into education. They say, the better I got, the better they got. Because I was learning more and I was responding rather than reacting. It's like they were getting better because they're feeding off of me. So if I learn more and I learn how to take that breath and back out of the room before I have a reaction, I remind myself I've got the 3-pound brain. I don't have the brain that's failing. They've got a failing brain. I've got a skill set, and I'm going to back out for a minute so that I respond rather than react. Schedules are important. Routines are important to somebody with FTD. Limiting their choices. Keeping that schedule. You want to reduce distractions and modify the environment. 80% of the time when someone has a challenging expression or a behavior, it's our approach or the environment is to blame. We're not doing it on purpose. We would never do it on purpose. But when we learn more, when we learn better, we do better. When we know better, we do better. And let's look at the environment. Are they seeing shadows? Are they seeing holes where there's a rug? Everything's changing. So modify the environment for them. Now, are they going to be able to tell you what needs to be done? No. You've got to figure it out. You've got to do these classes. You've got to learn. And if you ask your loved one something, what are they probably going to say? Are you hurting? No. Do you want something to eat? No. Do you need to go? No. No's one of the first 5 words they ever learned, and no will stay with them. We got to learn to figure out the feeling and the emotion and read them. If compulsive eating becomes an issue, and it's really common in people who have the FTDs, we can start supervising eating. We can also limit some choices. I've had people who've had to lock cabinets and refrigerators and distract. They become masters of distraction, distracting them away to other activities because we need a lot of help. I need your help with. Lots of times that works. I need your help when we make it about us and not about them. Again, medications are there to treat behavioral symptoms. Antidepressants are very commonly prescribed because that helps with social disinhibition and impulsive behavior. Now, we hear antidepressant, well, they don't look like they're depressed to me. But keep in mind, lots of medications have multiple uses, and there's a lot of antidepressants that can help with impulsive behaviors. We also might have to use an antipsychotic in people who are having a lot of aggression. This is temporary. All of this is temporary because this is a progressive disease that's going to move forward, and they will come out of this phase or stage. I promise they will. When we're in the middle of it, it doesn't feel like it, but they will. I promise that they will. So we're going to tailor that treatment to a person's specific language problem. We're going to use that speech therapist. All of the dementias, your loved one should go in and out of physical therapy, occupational therapy, and speech therapy. But with the frontotemporal dementias, we're going to have a lot of speech therapy, especially if they've got the aphasia. What about using a notebook or a whiteboard? If they can still read and comprehend. Now, there may come a time that they can read but not comprehend. So just be careful with it. But if it'll work for a little while, use it. Start to talk with a lot of gestures and body language and facial expressions, and bring our sentences down to 2 to 3 words. Sit here, watch our tone. I'm patting the chair and I'm sitting down so they'll mirror me. Make sure that we speak slowly. We need to enunciate simple sentences and then give them time to respond. It can take up to 20 seconds for someone with any dementia to respond back, but we are the ones that get in a hurry. We are the ones that are, did you hear me? I said, give them time. Think about what's happened. All this we just talked about in the last 45 minutes. I've got to hear what you say. Then I've got to compute and figure out, and then I've got to do something, and it's going to take me a second. Remember that picture of those brains we looked at? They've got a failing brain. Give them a minute to process. I've watched people actually fall on their face, hit with their face, and then put their hands out because their body didn't connect that they were falling till they'd already hit the ground. Time's important. Again, there are some medications and some physical and occupational therapy that can be provided for movement symptoms. And again, those are temporary. This is just something that we're going to work through this phase of. There are, for people that have the corticobasal syndrome or the Parkinson's disease, some of those medications can help with some temporary improvement. Again, you'll see it over and over: physical therapy, occupational therapy, and speech therapy. If you think that it's time that your loved one needs to do another round of therapy, ask the doctor for it. Worst thing they can do is say no, that they don't think it's time for it. Be their advocate, be their voice. Now, some people, especially those, this last paragraph, that have FTD-ALS, can decline rather quickly. It can be 2 to 3 years because of the ALS aspect of it. Physical therapy can really help a lot with those muscle symptoms. Everybody who has dementia at some point is going to end up on that walker or in the wheelchair, just as the disease is progressing and the brain is damaged. The ALS symptoms of the disorder typically will affect them physically before the FTD symptoms do if they have that dual diagnosis. If they are having compulsive behaviors or those really negative, challenging expressions, try to identify the triggers. Keep a journal. Keep it on your notes page on your phone and look for the pattern. What's happening right before the behavior? Who's around? What time is it? What's on the TV? What room are they in? You may start finding a pattern. I've sure had that happen with people before where we start tracking it. Well, every day about 2, they do this and such is coming on the TV. Something on that show's triggering something in them. We got to stop watching that for right now. I had it happen with MASH in the day program where I had MASH on, but I also had some veterans. And even though MASH was called a dramedy, it was funny, but there was some drama. If you were a medic in Vietnam, maybe I don't need to be watching MASH. We had to put it together. We had to find the pattern. Maintaining a routine, trying to get some daily physical activity in is going to be important as much as they can do and help them feel better. It's going to help you feel better too. And then validate their feelings. Don't try to play their feelings down. Validate their feelings. Okay. Okay is a great word to say to somebody with FTD. Okay. I heard you. Okay. This is hard. This is hard, isn't it? We're going to do it together. I'm right here with you. Try to fix the problem. We talk about validate, fix, distract. Try to fix the problem. And sometimes we have to fix it with a therapeutic story. Is that a lie? Yes, it is. It is a lie. It's a little lie. It's a therapeutic story. Somebody took all my money. Well, then I'm going to call the bank and get it fixed. And you're not calling the bank. You're not calling anything. You're pretending to be on the phone. Validate their feeling. Fix it. Don't try to be reasonable or rational and then distract them. One of the symptoms of this disease is that they can't multitask. That also means they can't hold 2 thoughts at a time. So if I can get you only over here on this ice cream, or I can get you only over here listening to this music and holding this rabbit, or I can get you only over here watching this video of children laughing while you're eating ice cream. Distraction. Validate, fix, distract. Modify the environment. Be careful with noise and stimulation. A person with FTD often has a high startle reflex, where you or I might not even notice the air coming off and on, and we notice that they're over there jumping every once in a while because they're hypersensitive. Reduce clutter and then simplify social situations. So, neuropalliative care. This is something interesting. This is actually a new and growing field. And if you are in North Central Texas, we have got neuropalliative physicians because I've got a couple of people who are going to them. Listen to this quote. Neuropalliative care is a new and growing field within neurology that focuses on improving the quality of life of patients with serious neurological illnesses. It can be started at the time of diagnosis. It changes as the disease progresses, eventually becoming hospice care. And listen to what it focuses on. The word cure isn't in here anywhere because this isn't curative. We don't have curative medicine for FTD yet, but it focuses on relieving physical, emotional, and spiritual distress. I'd not heard of it when I first put this program together several years ago. And then I had someone send me some links to some neuropalliative doctors in North Central Texas. And I just had somebody send me one again within the last 10 days. So neuropalliative care, it's where it's a neurologist that's more about the palliative side of FTD or any other type of dementia, where they focus more on the physical, emotional, and spiritual distress and staying comfortable, not curative, because we don't have a cure. This is the conclusion, and these are our resources. So we've got lots of resources here for you. I've got the phone number to the AFTD. I've also got the website to the AFTD. The National Institute on Aging has some fantastic information on FTD. We've got it there for you. There's the FTD Disorders Registry, where you can find out information about possibly being in some research opportunities. We encourage you to get into either one of our support groups that is for all people who have loved ones with dementia, or get into a specific FTD support group, which you can find them on the aftd.org. They are not easy to live with. None of the dementias are easy to live with, but the FTDs can be especially challenging because of the behavioral parts of it that come out. This is our information here at the West Center. We are glad you were here today. We've still got about 2 minutes. I'm going to see if Jamie had anything that came up in the chat.
Yeah, well, there was a handful of things in chat, and I tried to answer as I saw them, but you might have some also insight into some of those.
Somebody's asking for the list of the neuropalliative care neurologist list. Sharon, if you'll email me, I've got the name of a couple. I know that there's one, maybe two at UT Southwest in Dallas, but we've got them here in the DFW area. And you can also Google neuropalliative care DFW and see what comes up. More incidents on different cultures on sex and experience behavior sex or women more content. Oh, studies with the male versus female. Oh, yeah. Which culture has more incidents of FTDs? Do you know about cultures, Jamie, with FTD?
No, I don't. I'm not aware of any
I know about the
studies.
male versus female.
I don't know of any of those, and I mean, I kind of looked at that, but I didn't see anything specific to cultures by any means. So, but that doesn't mean they're not or that they shouldn't be having studies on them either. So.
For different FTDs, is a PET scan versus an MRI more helpful in diagnosing? They can diagnose with an MRI because they can see it. Now, a PET scan is just so much. MRI is a very basic scan. MRI, CAT scan, PET scan. The thing with PET scans is most of the time insurance does not want to pay for it because they are really expensive. The last I heard, they're about $8,500. Can surgery where the frontal lobe was cut twice cause FTD later in life, such as a placement of a shunt and the maintenance of a shunt that impacted the frontal lobe? Yes. So anything that had some type of a disruption to the blood flow in that area, could that contribute to it? It could contribute to it. Could it also contribute to something vascular? It could contribute to something vascular. And we now know, the statistic now is that, oh, and we're right at time, that about 80% of people who die with any type of dementia also had vascular. Maybe they didn't even know it because they had some type of vascular issue going on. We appreciate all of the questions. You can continue to send questions to me or to Jamie, and we will get back with you in 2 different dementias. Yes, absolutely. It could be 2 different dementias. Asking about the 2 different dementias. It's much more common than is diagnosed where people have 2 different dementias. It's called mixed dementia. Thank you all for being here. This will be up on our YouTube page as well. On our YouTube page, if you haven't ever been there, there's dozens of videos that are out there that Jamie and I have done. So please go. It's James L. West Center for Dementia Care. You can even search and find all kinds of information. We appreciate you being here today. Thanks, everybody.
Thank you.
Bye-bye.